Ready to get started?
Let's go for it.
Okay, let's go for it. Hi, I'm Tyson Franklin, and welcome to this week's episode of the Podiatry Legends podcast. With me today is Podiatric Surgeon, Dr. Kent Hungerford, and he is from South Coast Foot Surgery in Shellharbour, New South Wales. If you have not been there, it is a beautiful place. I haven't been there. I've just seen photos of it, and it looks like a beautiful place. And today, we're going to talk about injection therapies, but before we get into that, I want to know more about Kent. So, Kent, how are you doing this morning?
I'm going very well. Yeah, it's a bit of a rainy day here on the South Coast, but we're doing pretty well overall.
I've seen photos of Shellharbour, and it looks absolutely gorgeous. Yeah,
it's a really nice place. And I grew up here on the South Coast, just south of, about 15 minutes south in Kiama. Really nice touristy type town looking straight over the beach, and Shellharbour is absolutely no different.
So it's so you're from that area initially? That's where you grew up?
That's where I grew up, and before I sort of kicked into all my training and did my tour of the states, as I call it, the Australian states, that is. But definitely grew up here in on the South Coast. Pretty much was a beach boy, and really enjoyed it.
So before we get into the injection therapies, so what took you into podiatry in the first place? I'm always interested on what got you in there.
That's it. And I think like a few people, I sort of fell into podiatry. I was doing a lot with the Air Force cadets as a teenager, and I still actually am an officer with the Air Force cadets in youth development side at the moment, and that's sort of my community side of life. But I wanted to be a helicopter pilot, and at the time going into the Defence Force. After passing all my advanced testing, they did a medical, and they said because I was wearing orthotics, that I had to do 12 months without them. At the time, I thought this is crazy. And now I know that it was crazy because, 12 months without orthotics would have caused me problems. But because of that, I put in, a few different Year 12 selections around health sciences, prosthetics and orthotics, and podiatry. Podiatry I ended up putting first and managed to jump into podiatry that way.
So where did you end up? Did you study in New South Wales?
I ended up going down to Albury-Wodonga for my first year. And so through La Trobe University, you could, the Bachelor of Health Science, Master's Podiatry, you do a sort of common first year. And so I did that through one of their regional campuses in Wodonga before moving to Bendigo to, as sort of the rural health school course there. Now, I understand that it's all been centralised out of the Bundoora campus in Melbourne now. But I knew when I finished my Year 12 that I just wanted to get out of town and see the world as such.
I didn't realise it was in Bendigo for a certain period of time there.
Yeah, so I only did the first year. So basically, I think there was only 2 of us podiatrists in Wodonga for that first year, and then we went together and we had 17 of us in our graduating year. So it was good being a small cohort. I really enjoyed it. I know out of Bundoora in Melbourne, they had about 90 graduates of the same year. And I think we got a lot, more comprehensive exposure, and I found it quite good with that rural health emphasis, particularly practicing, more regional as I am at the moment.
Yeah, well, when I graduated too, and that was going back, like 100 years ago, there wasn't a lot of us that graduated at the time. What year did you graduate?
From uni 2014, end of 2014, yeah.
Okay, so when you started podiatry from day dot, did you know, I want to be a podiatric surgeon, or did that just sort of develop once you went into it? You went,
I sort of found, I didn't even know podiatric surgery was a thing, like a lot of us when we started. And, what's this podiatric surgeon sort of thing, and as I sort of moved through into my second year, I sort of got introduced to it. And of course, we had a few lecturers in Dr. Gil Heaney and Dr. Dean Samaras in Melbourne, which was really good. But I sort of thought, oh, this is something I could do. And when we got to our third year and we're doing our injectables and minor procedures, I almost aced that unit, and I was thinking, I really am interested in that. And so for my grad year, I was able to get in with a podiatric surgeon, and was able to secure that position early, and was able to then see a little bit more and get exposed before I was accepted into the Doctor of Clinical Podiatry, which is now the Doctor of Podiatric Surgery through the University of Western Australia.
Oh, right. Okay. So from you starting podiatry, like starting first year, through to being qualified podiatric surgeon, how many years did that actually take you?
I want to say 9 years. So from first year undergrad to finishing, yeah, I think it was 9 years.
That's
So
not too
about,
bad.
yeah, I think I got through it as quick as I could. And I think my approach was, in having moved from sort of I was in Canberra at the time
Yeah.
when I got accepted into UWA, and when I went over there, my focus was to become a podiatric surgeon. And so although I did a little bit of work on the side, it was very much, okay, whatever theatre time I can get, I want that exposure and I want to jump in. So I was very much pushing uphill to get all that experience. And of course, a few trips overseas and 3 months in Shanghai, and all the public and private rotations locally and abroad. It was a fantastic experience that's put me in a very educated position at the moment.
Well, so was the plan always to go back to your hometown? You always knew, when I become a podiatrist or a pediatric surgeon, I want to go back to Kiama, where you are,
Yeah, so I've
or
got a
Shellharbour.
really close family. And 3 older brothers and my parents, and we all live within about 3-4 kilometres of each other.
Okay.
And so me being 4,000 kilometres away in Perth wasn't really working. So I came back, and now I'm only about 2 k's away, and that was sort of the whole idea. And I sort of have a joke with people. I've always called myself geographically unstable, in that I'm moving around everywhere for my training. But now I'm feeling like, I'm going to stay within this region at the very worst, because I've got some amazing rooms here in Shellharbour that I'm consulting and doing minor procedures out of, with a procedures room, and I can't imagine leaving it, put it that way.
Yeah, but like I said, it's a beautiful part of the world. And it's the same reason I stay. Yeah, I've never left Queensland to live anywhere else, because I love the heat. I love being near the beach. So I grew up Gold Coast, and I live in Cairns.
Yeah.
So when I've got friends down in Canberra, it'll be middle of winter, and I send them a photo of us having, like a wine on the beach in the afternoon, and they're in Canberra and it's like -2, and they just go, "You bastards."
Even today, it's not cold, but it's that dreary rain that's set in.
Yeah.
And how many days of this have we got? When I know, you might have your afternoon shower, but I'm pretty jealous of those mornings.
So what was it about injection therapies that interested you more than anything else? Because you've been running courses on them as well, and the current one that's coming up early February is sold out,
That's
which
it.
is
So
fantastic. So what was it about that you really liked?
yeah, so injection therapies, I think, is something that's really undersold in podiatry and health and medicine generally. I think that the approach and how we look at pain is something that's, really undercooked at an undergraduate level, and it's really on us to try and explain pain a little bit further
And
to our patients.
just to point out to everybody too, sorry to interrupt, we're talking about injection therapies as in pain management for certain problems, not injection therapies for cosmetic reasons.
No,
Right.
that's it. I have to say, someone asked me, can you touch on Botox? And I thought, oh, I'm going to have to look into that a little bit more. But yeah, obviously you've got Botox for plantar fasciopathies,
Yeah.
but it's not something that I cover off. And definitely the cosmetic side is not something that we cover off as well. The way that I approach injection therapies is very much from like a high volume injection type of idea. And after introducing a lot of the different pain theories, like your gate theory, as well as some of your peripheral and central sensitization, to try and better understand, okay, what's happening at a neuron level, what's happening at the brain level, is then saying, okay, well, what are we targeting? When do we target? And I then start thinking, and my biggest thing for people when I introduce them is, as soon as a patient comes in saying that they've got burning pain, and it's very typical to a dermatome, whether that's the tibial or your superficial perineal, I say, oh great, burning pain's a great sensation, because that lets me know straight away that it's a very localized nociceptive pain, which means that the entrapment or the nerve injury is going to be localized. I
Okay.
almost immediately can get rid of the fact that it's not necessarily from the back, although there can be contributions from it. It means that I can treat locally. And so for me, and as a podiatrist, as a podiatric surgeon, it's something we can do for these patients that are in such significant pain that our typical options can't work. Orthoses aren't going to fix the adhesions of a nerve. Neither shockwave, massage and dry needling can help. But I haven't found anything that is as effective as injection therapy. And I use a lot of laser therapy in combination, so photobiomodulation therapy,
Yeah.
proper name. But between the two of those, I just find that it's a really good option for patients that have come through that, have seen everyone, but, I can get them out of pain in, potentially one, but typically 2 or 3 sessions.
Okay. So like every podiatrist can use lignocaine, but do you need to have prescribing rights to do other injectables? Is there a limitation to what the average podiatrist can do?
Yeah, that's it. And it's a really good question there, Tyson, because, as podiatrists, again, we're not sure what we can use in each state. And, a lot of states, and I think Victoria is the exception here, that you can use ropivacaine or bupivacaine, which are our longer lasting local anesthetics. Now, when we can start to use those longer acting local anesthetics, that means that we're starting to really act within the cycle of pain on the brain and the psychology side of that as well. Because being out of pain for a period of time is healing in itself, and it's allowing the brain to sort of do, what I call the reset and say, well, that pain signal is not normal. I'm now cognitively aware of that, psychologically aware of that, and can then start undertaking normal movement and hopefully get that reset undertaken. And when we do those injections, obviously, a high volume injection for me is, anywhere from 20 mils and up. Yeah. And when we're injecting, say, maybe 10 mils of ropivacaine or bupivacaine, 5 mils of lidocaine, and the remainder is saline, means that we can really start to expand out what we're seeing in that area. And let's take the tarsal tunnel, for instance. We get a lot of burning pain in conjunction with our plantar fascial pain. And I may put 20 mils into a tarsal tunnel to spread and release adhesions in that area, as well as releasing some of those sort of lateral or the medial calcaneal nerve that's in that area too. So, it's all about, okay, where is the pain? What have the dermatomes been affected? And how can we release these nerves in a way that will provide, a pain relief for the patient, whilst also resetting that sort of pain cycle to the brain as well.
That's great. So any podiatrist that is already using lignocaine can use the other anesthetics.
That's it.
And do the course without any problems whatsoever.
Absolutely. And, we do talk on prolotherapy, and prolotherapy is something that I haven't talked about or haven't done as much of. And with some of our course participants, we've really built up this body of knowledge, which is great, using dextrose. And of course, everyone can buy dextrose. It's not a restricted medication. And so even those in Victoria that are using a lot of lidocaine, and maybe using some dextrose at the moment for their prolotherapy, it's really about looking at the different theories and models around that we can then build up. And one of the best things that I've enjoyed about my course and offering that course is the community that we build. And we do that, the fortnightly Zooms during those courses to really consolidate our learning, build that community, see what people have already done previously, building that comfort and confidence in which cases they are most appropriate to undertake those injections for as well. And that's really the emphasis, is building that comfort, but through the community and being able to ask those questions. And, I'm having people now putting up their own videos of the injections they're doing and getting the feedback. And for me, I think that's great.
So what's the most common problems that podiatrists are doing this training and then applying it in their podiatry business on a regular basis? Because sometimes you can come and do a course and you learn something, oh, that's really, really cool, but then there's not a lot of practical application to use it. So what are the most common things that people are doing in their practice after doing the course?
Yeah. So first of all, think of every condition that you're looking at and think, okay, is there a nervy component to it? Now, nervy, your tingling, your pins and needles, your potential trapment, definitely your burning, those sort of things. Then we go, okay, this is what I'm looking at. but then also consider, okay, is it a nerve that's impacted? And so when we start thinking about that, we start looking at our, potentially our recalcitrant plantar fasciopathies, whether they're a fasciitis or there's something a bit more happening there. Think about your Morton's neuromas, your tarsometatarsal joint arthrosis, all these sort of things that are then, okay, well, there's a bit of arthritis, but then we do interjoint sort of injections as well. And I think that's a really big part of it too. And whilst I talk on this, I want to say, steroid injections isn't necessarily something that I spend a lot of time on. Yeah. My go-to injection as a podiatric surgeon is exactly lidocaine, ropivacaine, and saline mixed into 20 mils and injected to release a lot of the nerves. And I find that works quite well. The evidence can be, we go through, quite a lot of evidence, of course. Evidence-based, clinical informed practice is sort of the way that I like to approach, podiatry generally. And I think there is a lot of evidence to say, even a saline injection as the sham can be almost as good as our steroid injections and our platelet-rich plasma injections. But of course, we go over those and getting an understanding of which is the most appropriate in which situation is really important, depending on, patient comorbidities, what they've tried previously, and having that discussion is a really valuable tool there too.
Why isn't there something that's taught in an undergraduate program? Like, why aren't the universities saying, hey, this works, we should be teaching this so every podiatrist is actually applying this in their practice?
I think that's a great point. And I think getting that comfort in injections and finding the right patients is another step up. And assessing and training, yes, I think that's really important. But, which graduate comes out and thinks that they're pretty comfortable in biomechanics? Let's get the core right. I appreciate what the universities are doing.
But
then there's other things, and I'll speak on the photobiomodulation therapy, the laser therapy. And I just think, I used to teach over at UWA and, provide that sort of a lecture just so that they have an awareness of where it's coming in. Because I think it's the lost side of medicine at the moment that obviously the pharmaceuticals have so much influence and money to be able to sell drugs. But then we've got this natural option as well. And so, again, in conjunction with our injection therapies, our laser therapies are a really big part that we need to be looking at as new grads and, right through to our senior podiatrists as well.
Yeah, so you were doing lectures at UWA. Are you doing the same lectures in New South Wales, like to the universities, just opening the students' minds up about this so then they can do extra training when they get out?
Absolutely. And so I've had a conscious approach to coming back east. Yeah. And of course that got thrown up in the air with COVID. But my whole thing over the last year and 2 years of being back on the East Coast is building my practice so that I can then be in a position to start, informing practice for the, next generation, as well as, the current podiatrists that are practicing as well. And so we're looking at doing quite a lot over the, coming year to 2 years through our company, My Health Education. And some people will be seeing a lot of that. And previously where we'd held the injection therapies training through another sort of group, we're now going to be holding that through My Health Education and providing a lot more information, not only about injections, not only for podiatrists, but broadly for health practitioners. And I know we even have a GP coming along to our next injections course, which is really good to see that interest broadly from the medical community.
Yeah, so and they're understanding the value of it. So the people that have done the course so far, what feedback are you getting? Is everybody applying everything, or is it like some things where they do the course and they don't have the confidence to sort of? Do you push people afterwards to, hey, what have you been doing? Tell us about your patients.
That's it. And so even this morning, I put on a bit of a post, just saying, okay, just checking in, happy hump day. What are we up to? And then a bit of a specific information that I wanted to pull out on vascular surgery, for instance. But yeah, it's something that I'm building that community for. And I know over the last few weeks, and we finished our last course at the end. I think it was the end of November. And we're still talking at least weekly. Someone's putting something up there, whether it's a new video, people are getting their phones out, the GoPro, I know I try to record everything with my GoPro mounted on sort of a headband. And I think that that's a really valuable thing, that we're getting that constant feedback. And, like yourself, Tyson, having that community and being involved is a really big part of encouraging and making people confident in their practice. Getting exposure past the course is really, really important. A lot of people are saying that, they're not necessarily comfortable with everything. But then I sort of say, okay, well, let's just start with a sural injection. Really superficial nerve, no major structures in the area, nothing can really go wrong. Let's see if we can find the right patient for you as they're coming through. And then, some people are happy to go right into it. So a lot of people are doing Morton's neuromas injections. A lot of people are doing tibial injections. And, particularly when it comes to, say, verruca procedures, they're happy doing a tibial block straight away before they do their local infiltration. And they're, right through. Some people that have been doing prolotherapy for quite a while using dextrose, I don't want to say it's the best course they've ever done, but that's the sort of, feedback.
Oh, no, you can say that.
Oh, well, then there's been several people, Tyson.
They said this is the best course I've ever done.
Yeah, that's it. You don't want to, I'm not one to sort of oversell myself or anything that I'm a part of, because
I think there's nothing wrong with shameless self-promotion.
Well, here I am.
So can I just ask you, so when people do the course, they finish it, they learn about injection therapy, you then have your Facebook page set up, private group for the people that have done the course. So each time a cohort finishes, they then join that group, and then they get to see everybody else that's in the group as well.
The best thing about this is, for the early adopters, they have been able to see, a few courses go through. And straight away they're into that bigger community group. And because I find the value in, it's not always necessary for me to put the comments in, but for people that are already putting it into practice in the shorter time since their course, they're able to offer that feedback. And I think, and at one point there was someone that said, oh, why aren't you thinking of an orthosis like this? Because it's bigger than just injection therapies. We need to be remembering we've got our standard, well evidenced, well practiced interventions too. And sometimes I get so excited about some of these injections courses and other things that we're doing that I forget that we've got tried and tested options as well. And I think having that community straight away from the outset to offer, okay, well, I do it a little bit differently to Kent. This is what I do, and I think that really builds.
That's good though. Away. Well, it's good because they learn from you, and sometimes the teacher can become the student when they learn something back. When I do might as well give myself a shameless plug, the 12-week podiatry business reboot, and everybody that does it at the end says, that was friggin' excellent. I got so much, I didn't realize there were so many parts of my business that I was not looking at. But while we're going through it, and because we talk each week, the feedback you get, somebody will say, oh, I did this. And I go, oh, bloody, that's a great idea. So then everybody learns, and that's the difference when you have that one-on-one meetings and talking as well as a group.
That's it. And I think the best case of this was I initially said, okay, we're going to do a 1 hour Zoom each fortnight. And then all of a sudden, 3 hours later, I'm going, okay, guys, it's like 9:30 here. I'm going to have to go to sleep. Because, and I think that's great, because we've just had, I'll go through and do a recap and put everyone's mind at ease and fill in the gaps that I may have missed through some of our pre-recordings. Really start answering some of those questions that are being put onto our Facebook group. But then we have that open case discussion where, it's led by everybody. And I think that's such a beneficial thing to have. And like you say, those conversations just keep on going.
So you've had 6 groups go through so far. Yeah. And I take it you're going to plan more throughout 2022?
Yeah, that's it. So we've got 3 to 4 months in between each course, and that sort of allows us to focus on a few different things. Definitely the injection therapies is one of those courses that we're really enjoying. And for the course after this one, I'm even going to be pre-recording or re-recording so that we can update our content as well. We've got a fantastic premises to the side of where we are. We're just about to start building out into there and putting a few more consulting rooms in, but also a little bit of a studio and training sort of lecture room as well. so that we can start offering some of that education in rooms, as well as just as a really nice recording spot to start re-recording and putting more content on. I know we've just locked in a ultrasonographer who I'm seriously excited about. In the name of Lisa Hackett, and she's another Sydney lady who has multiple years of ultrasound work and is just going to show podiatrists how to really use ultrasound in clinic. And this is going to be one of those courses not to be missed, but a really advanced way as well. And we'll be talking a bit more of that in our or seeing a little bit of her in action at our convention coming up in March as well.
Oh yeah, well, you mentioned, you just gave another shameless plug, which is fantastic. You've got a conference coming up, a 2-day event coming up.
Yeah, so March
21st and 22nd. Yeah,
March 21, 22 here in Kiama on the New South Wales South Coast. We've got this 2-day conference, and I think I'm actually going to be really annoyed by it, because we've put this agenda together. And so we've got 3 rooms going. So let me explain it a bit more. So we've got our main stage, which is going to be much more like lecture side. We've got our first breakout room, which is more of a workshop room, where we're going to be having our reps and suppliers come in with our ultrasounds, our shockwave therapy machines, our laser therapy machines, and we're going to be putting those into practice and seeing how they work. And then we've got another one, which is, for a bit more case discussion and a few different things. Now, the problem with this is that the agenda is so good that I don't know which room to go to. And that's my problem. But the best thing is they're all recorded. So they'll also be able to be viewed live for those that are a bit COVID aware and, not wishing to come across to New South Wales at this time. But then also, everything's going to be live online. We can access it for the month following. But we're really looking to have quite a few people there in person, because the speakers that we're getting through are, not only podiatrists, podiatric surgeons, physiotherapists, they're also a GP, an orthopedic foot and ankle surgeon, a vascular surgeon, and a few other pain management specialists who, his area is in minimally invasive pain procedures. And so we're really excited to put this convention on as our inaugural and hopefully an annual event here in Kiama. And so we'll be covering off a lot of, not only sort of content, with strengthening and, foot and ankle type of concerns. It's going to be injection courses, sort of minor content, ultrasound therapy, where it's used in clinical practices, laser therapies. There's so much there, a bit around business and marketing. There's just going to be so much there that should be for all people, whether they're podiatrists, physios. It's a lower limb conference. Yeah.
Sounds like the type of conference the associations should have done.
I will hold back comments here, because I think as a podiatrist myself, this is what I want to see. It's what's, and I think the reason it's in Kiama is because the South Coast of New South Wales really misses out sometimes with access to in-person events. And, we can't be everywhere. And, I think the association does a great job that way, in enabling as much online and in-person content. But for me, it's through my health education. This is really for the South Coast, but more broadly online, it's going to be something that we can all really access and get a lot of value from.
But that's the feedback I've heard from a lot of podiatrists, that the type of conference that you're putting on, and even though the course, the injection therapy course, these are the type of things that are becoming very popular with podiatrists now. They don't want to go and spend $1,000 or $1,800 if you're not a member of the association to go to a 3-day event where they look at the program and they go, theory hasn't been applied in practice, theory, good lecture. And when they look at it all, they go, 10-20% of it is something that they can really apply, 80% is not. So the feedback I've had from people is the type of thing you're putting on, they go, I know what that's all about. I know how I can apply that in my business. Therefore, I want to do it.
For us, that comes down to even the name. We're not holding a conference. I don't want a lecture happening. I want a convention. And a convention, by definition, is a discussion-based learning outlet. And although there will be a few lectures, it's very much going to be, okay, well, let's actually pull that speaker aside. We've given them a workshop after their lecture on stage, so we can start looking at the practical applications. And we're going to be working through so that we can get those questions offline for those that are viewing live, but also being able to access, you know, as much of that content as well. Because like I said, you know, which room do I go to? It's that's really the trickiest part of this, you know, convention for myself. I'm speaking at a time that I'd rather be in another room, let alone, you know, which room when there's 2 or 3 speakers at once.
I remember when I was in Liverpool, and it was the Foot and Ankle Show, and that was a brilliant event as well for a couple of days. And I remember Dave Cashley was up there, and he was talking about research he was doing around neuroma treatment. And lecture was great, but him hanging around afterwards, and I was getting a chance just to talk to him and ask questions. Then I had him on the podcast as well, gave me even more than what he spoke about up on stage. And plus he was a really funny speaker. So I like the idea of the lectures, getting up there talking, but then hanging about, doing a workshop afterwards to say, hey, this is how you apply it.
And like, even to the point where, yes, they do have that ability for the workshop, but we're hosting a dinner as well, you know, a 3-course dinner at the same function centre in Kiama that night. And that's going to be, all of our speakers have been provided with the dinner for that night, because we want them to be there. We want them to be able to have that connection and get to know people outside of that clinical space, even outside of that convention space, so that it's that social event that we've always wanted as practitioners, to, you know, let our hair down, or what we've got left of it.
Tell us about it.
Because that's what we're talking about. You know, we need to make these connections. And I know a lot of the speakers here, and for the in-person practitioners, it's going to be really important, because most of my speakers are local practitioners. And so to be building that network of practitioners is invaluable when it comes to, okay, I need a referral, I know this person, I know what they do, I know how they work. And that's what we've tried to really work on.
So how many people are you hoping to have at the event?
So we have a capacity for about 300 participants. With COVID and everything, we're expecting something around the 100 to 150 in person. Of course, you know, things can change, but, you know, as far as online goes, you know, the world's the limit basically. And we are going to be offering, you know, these tickets to international people and practitioners as well, because we know, particularly through COVID, that we haven't had as much exposure or access to some of these higher level conventions, and the ability to be able to, you know, re-watch and watch again in the month following is a really valuable option for us as busy practitioners. Because how do we keep up in the best of times?
So what's websites? So what's the website for the convention? What's the website for, even though the Injection Therapies is sold out, but I'm sure that website is going to be there for future, it'll be the same website for future events.
So at the moment, myhealtheducation.com.au is the way to go. For all the updates, My Health Education on Facebook is where you're going to find everything. Similar on Instagram. My Health Education is sort of the way to go and what we're looking at. Now, previously we have marketed that through Learn by SCFS. So you'll see a few different things there. Of course, we've undertaken some new branding, and My Health Education is the way to the future. And we're transitioning over to that sort of company name at the moment. And that's why we're going to be doing a lot of new recordings. I'm really excited to see those come out in the next 2 to 3 months.
So going back to the injection therapies, when you're actually applying it in your practice, at what point what's your success rate on certain problems in doing it, to then moving over to saying, nah, I need to do surgery now?
Yeah, and so this is a really key aspect that I spend a whole week talking about with regards to the implementation into practice. Because it's really nice to know what a local anaesthetic is, how it works, what a pain syndrome is, when to inject is the most important aspect. And I think when we then get a patient coming through, and the way that I explain it, and I've got it pretty much, you know, all the policies and procedures that I use, as well as how I actually explain this to a patient being the most important part. So typically the way that I explain to a patient for a start, and I'll come around to your actual question, is that I sort of say, if we have a 0 to 30% decrease in pain, then I may not be at the right nerve. I may have the wrong diagnosis, or there's something not quite right there. The injection therapy may not be the right option for you. If we have a 30 to 70% decrease in pain, that means we're on the right track. Big thumbs up. We're happy. It may be that we need to undertake another 1 or 2 injections as part of your course of treatment. Again, for myself, in conjunction with the photobiomodulation therapy. Now, if you're having 70% decrease in pain, that's when we high five and we wait for the footwear, the orthoses, and the laser therapy to really take effect. And I think that's a really important part for patients to come along that journey with me. And a lot of the time when I'm talking to practitioners about this, the reason I explain this to my patients from the outset is because they then come back to me and they said, hey, Kent, my heel pain's a lot better. I think it's about 50%. I'd like to have another injection now in line with what you told me last week. So already I'm saying, I'm being told my own treatment plan. And I think to have that patient buy into our treatment plan is a really, really powerful factor in their management and the psychology of pain as well.
So a big part of your training when you're teaching people through the course is that communication and outlining a proper treatment plan, not just having the patient sitting, I'm going to do this injection. Hey, let's just see what happens. Yeah. You were actually explaining the possible outcomes, the journey they're going to go on, and you want the patient to come on the journey with you, not just a one-off type injection.
Like for me, I don't know how well people can see this, but this is my, SCFS.
So anyone listening to the podcast can't see it, but that's all right. Go and watch the video.
So for those that are watching online, having a treatment plan where you can write down and highlight things for patients is a really valuable option. And so I give that to every patient, and it explains sort of what I'm looking at and why, so that I can then reinforce that verbal that we're looking at again. And so when we explain that to a patient, I might say, about 10% of people that I do injections on are going to be in that 0 to 30%, where it might not be for them, or, we've got the wrong diagnosis, or their symptoms aren't exactly right for it, but, it's our last shot pre-surgery. When they're in that sort of position, 10% is, an okay. It might be up to 15%. The next section where we're in that 30 to 70% decrease in pain, that's probably the majority of people. And that's going to be, potentially the next 70% of people, maybe up to 80. And then you've got that 10 to 20% of people that have a really good outcome from the one injection. You don't need to do any further treatment. They think you're fantastic and, catch you later. And I think that's a really good thing to be telling patients as well. So they've got a realistic idea of, okay, how likely am I to get a positive outcome? And then, of course, going through the risks and then financial consent as well. And, having a bit of a chat about that, I think, is really important, because particularly when we come out as a new grad, we don't understand what money is, and we always live to our own budget rather than the patient's budget when we first come out. We need to realize that, being pain-free is really important.
That's a good point.
So having that discussion around that as well.
I think it's a really good point. Anyone listening to this is, don't put your own beliefs and values around money onto the patient. They have their own beliefs and values.
Again, isn't it, Tyson? I'm sure I've had a look through your podcast, and I'm sure that there's one in there around that. Otherwise, getting someone to have a bit of a chat about that's a really important factor, because I think particularly as new grads, we can fall into that trap as I did myself as well.
Yeah, Jonathan Small and I have covered it a couple of times on a few episodes. And I don't usually give Jonathan Small's episodes a plug because he does it himself. No, but the information he talks about is all around that topic about money and mindset. And they're such good episodes that, and it's most of the guests that I have on, the feedback I get, especially from students, the number of students who have contacted me and said, I was thinking about leaving podiatry until I found your podcast.
Yeah. Isn't that great feedback?
Well, the thing is, they'll listen to this and I reckon they'll be bouncing off the walls listening to this, thinking, oh my God, I've got to do this when I graduate. I had a final question before we finish up on this particular topic, and then I'm going to get you back at some stage and we're going to talk about some other things. Older podiatrists, they've been in the practice for a while. they've probably done a little bit of continuing education. And I know there's a few that skills are great, knowledge is good, but the confidence of just being in a room with, say, younger podiatrists who may be more up to date in certain areas, will they be left? Will they feel like they're being left behind, or will they pick it up all pretty quickly?
And so I'd probably say about a third of my practitioners are over 50 that
Oh, good.
take my previous injections course. And I really value that as a younger practitioner myself, in that we're bouncing ideas off of each other. We've all come from such different experiences, and some of these practitioners are ones that have done injection therapies before, been quite comfortable and confident with it, and are then adding to those that are maybe younger in the profession as well. And I think it's really reinforcing to them. And, you know, I will give a shameless plug now, because one of the older practitioners came back saying, you know, it's made her change the focus of her practice. And whereas she was doing a lot of general care, she's now moved that more to the complex pain management in conjunction with laser therapies. And I think that's a really good bit of feedback in the way that, okay, we've got that missing link. We can see that the services are needed and that they're making an appropriate clinical outcome occur for the majority of our patients that we get through. And I think, yeah, that's really important. And like with that as well, and, you know, I'm going to take a step back to sort of that implementation in practice, because a big part of what I talk about is, you know, and when you said mindset, this sort of made me think, was that it's more of that mindset of that we're educating, we're not marketing. And whenever I approach, you know, what we typically look at as marketing, whether it's talking with other practitioners or talking with, you know, our patients, I'm here to educate. I'm not here to market and sell myself. I'm here to give you all the information so that you can make the best options available for your patients, or as a patient, make the best choice as to which way your plan will go.
I think that is, I was going to ask you for a final tip, but I think that is a brilliant final tip and a great way to wrap up this episode. So, Kent, I want to thank you for coming on the Podiatry Legends podcast, sharing your knowledge, talking about injection therapies, and I will definitely be getting you back on in the not too distant future to talk about another subject.
Sounds pretty good, Tyson. Thanks for your time as well. Cheers.